In the consumer space, when it comes to my Doritos or my, toilet paper or, some office supplies, I'm okay with getting a different quality of gel pen or getting, something, taking the risk of building out a supplier network and working with different suppliers and potentially slightly longer lead times or, whatever it may be. But when it comes to life and death, that is really the risk that people take on in the healthcare space. We just see a slower evolution.
Hello, and welcome to Speaking of Supply Chain, where we explore trends, current events, and innovations impacting the supply chain and logistics industries. I'm your host, Ellen Wood. Today, I am joined by Luká Yancopoulos. And you know what? I should double check. Is that how we pronounce your name?
That's exactly how you pronounce my name. It sounds like you got, I don't know, maybe some friends who are Greek or something.
You know what? I love Greek food. But today...
You've read a lot of Greek menus.
I have. And I watched My Big Fat Greek Wedding way too many times when it was new. So, okay. But anyway, today I am joined by Luká Yancopoulos, and he's going to share some of his insights into the difficulties supply chains of healthcare systems are facing right now and some of the ways that they're addressing them. Luká, welcome to the show.
Thank you for having me, Ellen. I'm a big fan of the show, and I'm glad to be on this side of the microphone for once. So glad to be
here. Wonderful. So we have a very big topic today, but first let's take a moment. And I want to ask you, what is something that you feel we could do in this day and age? We do a lot of virtual meetings. We're doing a virtual podcast right now. What's something we can do to improve the quality of virtual meetings? Have you thought of anything that could do it? Because I hate virtual meetings.
Yeah, I think there's a lot of things that I hate about virtual meetings. And I think it's the part of the sort of meeting that separates or feels distinctly different from a real human experience or a real meeting, right? And those are the spots to make improvement, because what we like about, real meetings versus virtual meetings is there's something magic in the reality side of it. And I think two big parts I would like to change in how we meet virtually in the future would be, for one, in a conversation, I don't have a mirror looking at myself every time I speak. And I think that for a lot of people, it puts us into a place of like self-consciousness or self-reflection, when that's not the point of a meeting or a conversation. The point of a meeting or conversation is to absorb information from your counterpart in conversation.
Right, not to look at yourself and make sure.
Yourself and critique. Yeah. So I think that would be a cool thing, right? Is not showing the speaker to self, but instead, focusing on the communication feedback from your audience or from your meeting team members. I think the other part about it is, this idea of a virtual meeting. It's a discrete time on a calendar that you join and you're there for a moment, and it lacks the real part of like an office place or the building where meetings normally happen. I think sometimes the best ideas or the best conversations happen between meetings when it's not on the schedule, and when coincidence and circumstance leads to a magical little moment where you realize something in a conversation, getting a coffee with someone. And if there's some way to let people feel like they can go over to their buddies or their work buddy's desk and share an idea in the middle of the day without having it on the calendar, I think that would be a huge step forward for the virtual meeting space. But it's not my industry, not your industry. So who knows? Maybe these are terrible ideas.
Yeah, no, but I agree with you 100%. I love being in the office. I'm obviously in our office today, and I love being in the office to do exactly what you said, to just walk over to a colleague's desk. Hey, I had this idea, or I thought of something, and spitball, or go grab a coffee to the water cooler. We have a fantastic office manager who makes sure that our fridge is stocked with snacks. So, getting snacks and, that community of the office is something that is missing from the virtual and hybrid workspaces. And I think you're absolutely right. Looking at yourself on camera, I do it to myself too. But looking at yourself when you're in a virtual meeting is a distraction. I think the biggest thing we could do to improve virtual meetings, and this is something that I learned very early on in my career when I was a restaurant manager, and that was when you have a meeting, have your meeting, be where your feet are, be here now. And I think a lot of times we're so busy or we're trying to cram so much into our day that when we have a virtual meeting, we're just kind of phoning it in, for lack of a better descriptor of that, of just trying to multitask, looking on your phone, you're getting dinged with other messages. Like, virtual meetings need to be as dedicated in-person attention as if you were sitting across the table from somebody live.
I couldn't
I
agree
think that
more.
makes all the
Yeah.
difference.
And I think we're really hitting the ends of the spectrum here, right? With the shortcut, virtual meetings as they stand now are somewhere in the middle, right? Like, they don't allow you to have the fully engaged, fully present conversation that you're talking about, that you do get in a one-on-one conversation when the screens are away and the devices are down and you're looking someone in the eyes and communicating with them. And on the other hand, they fail to capture the outside the screen experience or the full community aspect that can exist, in the hallways, in the in-between places of an
Mhm.
actual workspace. So growing in both directions would be a great accomplishment for the virtual meeting space.
I think the other thing that could make meetings better is just blanket. Every meeting has to have snacks, because you're gonna get you're you're gonna get people who will talk more over food, or we'll go out with friends for dinner or drinks and talk for hours. And in meetings, you can't get anybody to talk. You need some food. You need something to break the ice.
Totally. Like an icebreaker question.
Exactly, like an icebreaker question. All right. So now that we've done our icebreaker question and we're good and ready to talk, let's talk a little bit about the healthcare supply chain. So I read an article that you wrote last year about the COVID crisis and how it highlighted all of the things that were wrong in the healthcare supply chain, or maybe not all of the things, but it highlighted some of the big problems that existed previously in the supply chain and allowed us the opportunity to come back and fix it, or change the way that we approach some of the things. So, what were some of the things that you saw in pre-COVID, or during that disruption, that were the biggest problems?
For one, I mean, one of the biggest problems that we see is that in healthcare, supply chains are chains that are as strong or as weak as the weakest link. And
Absolutely.
that's because they are truly linear chains, right? End users of these supplies typically will work with a singular supplier primarily, right? Even big hospitals, 90% of their spend is with one of these major distributors, right? The major distributors that dominate the space are owning 10 to 30%, right? Like of the market or of the end consumer spend, which is insane. We've got companies like McKesson who are doing $300 billion in revenue, right? Companies like AmerisourceBergen doing $100 billion in revenue. And all of this gets funneled into these sort of, again, linear chains. And when McKesson has a shortage, when the major distributor has a shortage, who is impacted? Thousands, maybe even millions of customers and healthcare businesses are unable to get the supplies they need. And that chain breaks because the one weak link sort of fails. We fail to have diversity or a diverse portfolio of supply chains that could allow us to change from being, as strong or as weak as the weakest link to as strong as the aggregation of our entire sort of portfolio of suppliers. I think a lot of other industries, you'll see people have multiple sources from which they can sort of shop or acquire supplies, right, that are interchangeable, right? And they go out and they bid each year, right, for different service providers to earn business in these supply chains. But it's not how it looks in healthcare. There is, the Federal Trade Commission in the United States is investigating a lot of these companies for antitrust violations and monopolization. And I think that makes us specifically prone and susceptible to impacts when there's a local shortage with the major distributor. That is felt all through the supply chain and everywhere. And if people had more optionality, a diverse sort of palette of suppliers with whom they could work, plug in to those different sources interchangeably, right, without effort, that would be a huge difference maker to preventing the shortages that we not only saw during COVID, but continue to see to this day. Diversification is always great in almost every setting.
So I hear what you're saying about the diversification of suppliers, but why do you think the healthcare industry was so hesitant to adopt that practice previously? If other supply chains were doing it, if other businesses, if other industries had a more diverse supplier network and went out to bid more often on these things, is it because there simply weren't the distributors available, or was it too much of a headache to have to manage that process? Like, what made healthcare so different that they weren't willing to adopt these practices before there was a problem? Did they feel like the distributors were solving, any number of problems and making it simpler by being a single source?
I think that, of course, humans are creatures of habit. And when there are risks associated with change, we prefer to avoid those risks. And we become even more so creatures of habit. And in the healthcare space, change, or I guess the risks associated with change, are ultimate. They are life and death. They are, at the greatest scale, the greatest problems that I personally care about, right? Like for my family and my loved ones. So I think people fall into that trap in this space more than almost any other industry. This idea of if it ain't broke, don't fix it. And we can get away with what's worked historically, and a change, even if it's going to save us, a lot of money or some future, from some future problem that we're not dealing with today. We don't need to make that change because it's just not worth the 1% or the 0.1% risk. So when you talk about like diverse portfolios of suppliers and having optionality, right, that makes you more resilient, like Amazon is sort of the ultimate example of that, right? And in the consumer space, when it comes to my Doritos or my, toilet paper or, some office supplies, I'm okay with getting a different quality of gel pen, or getting, something, taking the risk of building out a supplier network and working with different suppliers and potentially slightly longer lead times, or, whatever it may be. But when it comes to life and death, that is really the risk that people take on in the healthcare space. We just see a slower evolution. I mean, and it's not just in supply chains, right? You see the same thing with clinical trials, right, of drugs and drug development. We see the timeline to approve a vaccine during normal times when the outcomes are known and the risks are relatively low. Those things take a long time. They take 10, 15, 20 years in some cases, right? But when we talk about, COVID, they're rolling out vaccines within a year or two. Point is, adversity is often the parent of innovation, and it drives change where there otherwise wouldn't be change. And sometimes something bad has to happen for people to realize, that it's time for change.
So I hear that the stakes are just too high. The stakes are too high, or they were too high to risk taking the time or making the effort to diversify. So Grapevine, which is your marketplace, takes away that risk. How?
Yeah. And we are not sort of like, sometimes people call us like the Amazon of healthcare, right? And maybe one day, but that is not what we do today. We allow you to optimize, right, your spend across your existing trusted suppliers, right? So it's more procurement software than it is marketplace, but we layer that in some marketplace components, and you are right to sort of call us that. But the way that we sort of de-risk diversification is the suppliers you currently work with. You type your credentials, into Grapevine, your login credentials. We reach out to, let's just say, your McKesson profile. your Henry Schein profile, your Medline profile, your AmerisourceBergen profile. We bring in all of your order history with your active pricing from each of those vendors, the ones that you know and you trust, right? The ones you already work with.
Due
Now, all of those
diligence is already
options,
done.
the due diligence is already done, right? So there is no risk at this point. There's literally no risk. All those options are now on one screen. The interesting thing is there's a huge overlap in the catalog offerings from your existing suppliers. So the first way that we're going to help you sort of save money or solve back orders and shortages is by putting everything on a one screen. And when that McKesson product goes out of stock, when McKesson has a supply chain disruption and they no longer have their Becton Dickinson or B. Braun sort of needles in stock, right, we're able to, as you sort of search for the product, as you try to click add to cart on this sort of blocked back-ordered McKesson item, we'll redirect you to one of your other trusted sources who has the same exact item at, but available. Or if you add to cart on the McKesson item because you've always ordered these items from McKesson just out of habit, right, we'll show you opportunities from your existing vendor network to switch and save. Same item, but here's an opportunity to switch the same SKU just from a different source and you'll save money. And by the way, it's one of the sources that you know and trust. So at this point, again, we've taken no risk. We're helping you solve back orders by optimizing your entire sort of supplier portfolio that you already know and work with, if you happen to work with them, and lower costs by directing traffic to the smartest source. That's sort of the first month of using Grapevine for most healthcare businesses. But where we start to introduce some risk or some things that increase diversification rather than just sort of optimization is by introducing you to new suppliers or recommending substitutes beyond the exact matches that I've already talked about, right? So we'll say, hey, you've been buying this from these suppliers. There's opportunities to switch and buy the same item from, again, one of your trusted suppliers. But how about working directly with the manufacturer now? Do you want to work directly with the manufacturer? Because they use Grapevine too, and they can connect with you. They're compatible to work with you. You don't need to play through a middleman and a markup. You don't need to deal with the markup or the back orders. Why don't you switch directly to the supplier? So we actually allow healthcare businesses or hospitals to unlock new suppliers and build out a more diverse portfolio through the Grapevine.
Okay. So it's not necessarily changing suppliers or even going out to market for new suppliers. It's just having all of the information in one place so that that procurement person, that manager of that healthcare system is able to make better choices based on availability and potentially if they have budget issues based on cost or based on speed of service, how many times do those aspects come into it rather than just this is easier to go shopping and order our supplies?
I would say that if someone works with a single supplier, right, there's not much Grapevine can do to lower the costs or solve your problems. If you work with multiple suppliers, right, let's say 2 to 3, by just working with 2 suppliers, you're typically spending like way too much with one supplier and not making great decisions. Grapevine allows you to make sort of the smartest decision at the point of purchase every time you purchase for every single product. And by just doing that with 2 suppliers, we see savings of about 30% on your monthly or annual spend. Again, no introduction of new suppliers, just by optimizing across like 2 suppliers, savings of about 30% and a reduction in back orders by about 50%, right? So there's a huge impact just by sort of optimizing. Take that a step further, right? You fold in more suppliers, the savings go up. We introduce you direct to manufacturer options, the savings go up. In our sort of greatest use cases where someone goes from working with one supplier to like, let's say 8 or 9, we see savings of up to 85% on their overall spend on supplies. And that's with a combination of sort of switching to smarter sources for the exact same products, but also folding in sort of similar or clinical substitutes for new products.
So one of the things that you mentioned in the article was that some of these best practices and optimized workflows are what are going to, for lack of a better word, heal the supply chain for these industries? Does this diversification fall under one of those best practices, that using only a single source is not going to be the best use of their time and effort and budget because they're missing out on too many opportunities?
Yeah, I think that is definitely a huge part of it. And both for the purpose of savings, but also the purpose of solving back orders. If you have 5, 6, 7 different sources to shop similar or even the same exact products, right? The odds that, like, and think about it as in a consumer experience, like the odds, if you go to CVS and they're out of stocking the toilet paper you like, and then you go to Duane Reade, and then you go to Walgreens, and you go to like 6 other places, someone's going to have what you need, right? So having different sources for the same supplies isn't just a way to optimize costs and lower your spend, but it's also a way to prevent back orders, to make sure that clinicians have the supplies they need, the implants they need to perform surgeries. You're not just, saving money for these businesses. You're actually making sure that procedures can happen on time, making sure the supply closet is stocked when physicians and patients need, that injectable, that drug, that whatever it may be. And that is a huge part of the solution, that we solve. And it's a big part of mending the supply chain. Through diversification, we can lower the cost of the United States' spend on these healthcare supplies by, I believe, more than 50%. And while doing that, you can lower the frequency of back orders, shortages that actually occur in the healthcare space, I think, by like 60, 70%. So yeah, mending the supply chain has to do with cost. It has to do with back orders. And those are two of the problems that we sort of attack with Grapevine.
Well, and something else that you had mentioned to me was that the inefficiencies cause medical goods to move 40 times slower than other industries. Is that true?
Yeah, and we've got all sorts of like mathematical models that help explain it, but
what's causing that?
I'll give you like an anecdote, because I think
Okay.
anecdotes are easier to understand than explaining data, at least in the podcast format. If this was, some charts we were circulating, it might be different. But our first business and our foray into this space was actually, and I guess without going too into our origin story, college dorm room friends, we are stuck in our dorm room as COVID sort of breaks out. My mom's a nurse. My dad's a scientific researcher. We're hearing about these supply chain shortages and supply chain for really the first time in our lives from our dorm room, and we want to help. So we start aggregating information, data from import records and FDA licensed databases, basically looking at the entire portfolio of options to say, okay, who has these supplies coming into the United States that we can connect to healthcare workers in need, right? And we connect some dots. We help out my mom, my loved ones that we care about, that we wanted to keep protected through these scary times. And that was our start. Now, to answer your question, shortly thereafter, we end up getting a call from one of these major medical distributors, right? And they want to purchase the supplies that we've been, distributing to their customers. And we're like, they clearly didn't understand what was going on. Yeah, they ended up buying several million masks. Within our first 18 months, we did $20 million of sales to major distributors, right? And we got to see exactly how these supply chains worked on the supply side, right? So we were feeding the beast, if you will, feeding these major distributors that serve, huge portions of the medical, the medical market. And what we're seeing is we're shipping truckloads of these supplies, like single product, to centralized, they call them like centralized DCs or distribution centers, right? Which is like, they got like 3 or 4 of them throughout the country. From there, they take the supplies, they break down the supplies, they shotgun it out to, all their different locations. Now, their Northeast regional location, not the central DC, but the regional DC, ends up having a local shortage. So what do? They shotgun more supplies from their centralized DC or from one of the other regional DCs, and they move it there, right? So we get this crazy flow of materials where when we say 40 times faster, like, what am I comparing that flow to? Which may sound standard for a lot of industries and commodity spaces. like the alternative and the most efficient use case is sending it not first to our warehouse and then to the centralized DC, not and then through all these different shipments, but sending it directly from the source in the United States that has it, the place where it's either imported to and stocked, right, directly to the end user, if that is possible. And for a lot of these wholesalers or importers or manufacturers, they don't have the capabilities of breaking it down to consumer scale, like a single box or a single case, and sending it directly to the end user. They don't have the logistics manpower. They don't have the warehousing staff. They don't have.
Right, because that's the whole point of a distribution center, is to take something that's in a large format, break it down into smaller formats, and supply the orders. So I guess kind of the question there is, doesn't that increase the cost overall, because all of these logistic activities have to take place before you can ship it directly to the user who needs it?
And that's a great point. It should increase the cost. And that's sort of the second part of Grapevine. We've been talking about Grapevine in the context of like the customer or the healthcare procurement person for most of our conversation today. But we also have built a full suite of technology that we hand directly to that first importer or the first sort of stock owner of these products in the United States. So to enable a manufacturer to work directly with an end user, right, and make a profit without incurring all these additional costs, we have our own sort of magic sauce that we do that allows them to tap into end consumers for really the first time. And most of our sort of manufacturer importer partners in the Grapevine network use exactly that. They didn't previously have the ability to sell to end consumers because it was too cost intensive. But now with Grapevine, they're able to do it effortlessly, without any thought, without any labor, without any extra costs. It can basically happen.
Okay. So doesn't that just in turn make you the middleman distributor?
Yeah, no, that's a fair point. And it's a good question. In a way, yes, but we don't incur the costs that the middleman, like, so let's like actually talk about the cost. So for one, our markup is 3% across the board, right? Which is significantly low. We take whoever's selling it and it gets marked up 3%. That's it. There's not a distributor in the United States that marks up something only 3% from their. Why? Because shipping it to your centralized DC is going to cost you what, 5%? It depends on the product line, but maybe 5 to 20%, depending on what the product is and how heavy it is and how much the product costs. And then the actual warehousing cost that you incur of owning the warehouse, that's another 5%. And then shipping it directly to the end user. We may call it free shipping as far as the customer is concerned, but we're still paying for shipping. Yeah. So if our take rate as the middleman or the distributor is, 3%, let's say, we're still marking it up 25, 30, 40% to cover the costs that we've incurred for shipping and warehousing along the way. And the more that we can enable, I guess, end users to easily, effortlessly, and without any cost, work with these sort of manufacturers and vice versa, the better off we are. And that isn't to say that there is a place for distributors. That's what I'm trying to say. And I see it, I think a little bit differently than at least the way the distributors of the healthcare industry, operate. But they offer a whole suite of services that are very important to end users, whether that's financing, right? Allowing people to take on net terms so manufacturers can keep production, the end users pay later. The manufacturers need to be paid now. So bridging that gap, the customer support and customer service, like the thinking, the relationships and handholding, like those things still exist, and they still exist in the Grapevine space. We've got a whole different school of users that are resellers, but the resellers do not need to have a warehouse. The resellers don't need to bring it in to a physical warehouse. They don't need to incur costs of warehousing, pick and packing, shipping, right? Like Grapevine does that, and it allows these resellers to work directly with manufacturers and focus on their core competency as a distributor, as a reseller, which is often PO financing and customer management, customer relationship management, and customer support. And yeah, I think they have a very important place. I think it's just a different place than is shaped out in the healthcare space to date.
So we're solving a lot of inefficiency and back orders, but you had mentioned that larger hospital systems or healthcare systems experience a significant number of back orders on a regular basis, how much can we actually change that and make sure that these materials, that these products are available to those healthcare systems? Because like we said at the beginning, the stakes are so high.
Yeah, yeah. I mean, we can impact it hugely, and not just through, okay, you've gotten a back order. Here's an alternative source that has it in stock, ready to ship. It can get to you by tomorrow, right? Like that part, I think is a sort of clear cut solution to the problem. But you still are waiting an extra day or two for the product. It just now comes, instead of in a month, it comes in like whatever 3 additional days. So not great, imperfect, but does cut back on the amount of time that you're stuck empty-handed. We do one step better, and we're in we haven't yet launched this, but I'm pretty excited about it. And this is the first time I'm talking about it actually publicly. We study the promises made by your supplier partners, right? If someone says, we're reading in all this information when you link a supplier, this is in stock, this is low stock, this is whatever, on back order, this is, and there's tons of different sort of stock statuses, we call them, from each of the different suppliers. But we read in all that information. We tell you, and we are analyzing actively, we tell you, how often your supplier holds true to the information they presented to you when they actually purchase. And for example, this supplier, maybe 10% of the time, and we're using machine learning and predictive analytics to do this, right? We study all the historical stock statuses and then the amount of time that it actually takes to deliver after they promise you at the point of purchase that it's going to be 3 days. Does it actually come in 3 days, or does it take 10 days, right? And we look at the difference between what their promise was at the point of purchase and what the actual delivery times were, where they said it wasn't going to be back ordered and it ends up being back ordered. And we use that information to predict and warn you of your dangerous or untrustworthy suppliers. So this supplier, you've got 10 products, in this order that are going out to supplier 1, but heads up, 1 in 6 products is usually on back order from the supplier, even though they say it's not. So and on average, it takes 50% longer. So we're using machine learning and predictive analytics to try to warn you of problems before you place your order, and really at the point of purchase, so you can make smarter and better decisions about which suppliers you work with, getting any insights into, the accuracy, honesty, and productivity of the supplier network that you build on Grapevine.
So, we're talking about obviously these suppliers, these producers, these distributors. And I know one of the other big challenges here is just to your point, when it comes to the amount of time to deliver that product. Oftentimes they are coming from Asia. Is nearshoring or onshoring of some of the production of these things, is that starting to become larger in the healthcare supply industry? I know it's a big topic across multiple industries. The tech industry is really big right now, looking at onshoring. There's a lot of production looking to come back to the US and North America. Is that also happening in the healthcare space?
Absolutely. It's definitely happening in the healthcare space, both in like the number of FDA licenses issued to manufacturers each year, increasing domestically, decreasing in certain countries, right? As far as like Grapevine's role in it, we exclusively work with supply partners, whether those are the resellers we talked about or the manufacturers or importers, people that have stock domestically in the United States. So this is an onshore project. We are focused on exclusively connecting you to suppliers that can deliver something, within a 2-week period, not internationally, by sea or air freight, but like have the product in a US warehouse. And that's our core competency is marrying the end user to the best possible suppliers that have real stock, in the United States, and inserting, middlemen and resellers, distributors in the places that are necessary to marry the two ends of that supply chain. Our supply chain starts in the US and it ends in the US.
Fantastic. So, any other success stories? So I've read a lot about your company. I've read some interesting things on LinkedIn that you've shared about innovation and creativity. What is a story or a case study or a end user, a client use case that you can share about Grapevine that would be your commercial, like the best case scenario or like a fantastic story about your clients and your product?
Where I'm torn in answering this question is there are the non-corporate, family or physician-owned, groups or the physician groups that own like a number of dermatology practices or oncology practices, and there are real people. Those are the ones that really move my heart. But then there's the ones that with the more impressive numbers, the institutes that are public companies with hundreds of locations spending millions of dollars, and we cut that spend by 50%. So I'll let you pick, Ellen. Do you want to hear more about the family touch and warm the heart, or the big numbers, flashy numbers?
Both?
Or we can do both.
Yeah, let's do both.
Okay, for sure. So one example, then I'll start with the numbers one. One example is the Oncology Institute of Hope and Wellness. They're a public company. Their stock ticker is TOI. And they've got something like 80 oncology practices or clinics across the United States that serve, cancer patients and give cancer treatment. They also do, clinical research to try to come up with and bolster the arsenal of oncology drugs and therapeutics that are available to their patients and so on. Before working, with Grapevine, and they were, and this is all public information because again, they're a public company, but before working with Grapevine, their spend was in the millions. They were working with and had registered with a number of suppliers, but about 98% of their spend was with one supplier because of the convenience of ordering on a single screen and not having to deal with multiple reps, multiple contacts, and whatever. We bring them into Grapevine. Within month one, they're saving about 20% on their supplies and redirecting, that almost full pie with one supplier to a healthy proportional number of suppliers that are actually earning the business, every single day. From there, we help register them with both new GPOs and new suppliers. Now they're working with, I think, like 12 suppliers. They've cut their spend by almost 50%, and if all goes well in June, they'll be above 50%. They don't spend more than 30% of their $1 million spend with any one supplier anymore, right? Every month they're healthily diversified pie of different opportunities, and when they get a back order, they don't notice. The product goes off their the product goes on back order from supplier one, who's got the best price or the whatever it is they're focused on. Sub out the product, the new product appears for them, they're redirected, and it's simple. They don't even see products that are on back order because the back orders solve themselves before they even place the order. That is, by the numbers we've saved them to date more than $650,000. They started basically in January of this year, and they've saved $650,000 through the year to date. So that is a huge use case. Again, it's like 49% savings and a lot more resilience. And that's by the numbers one of the greatest accomplishments we have to date. They've recycled that money right into serving oncology patients and saving lives, and that's been something that I appreciate and am happy to see. As far as like the heartfelt stories, I'll talk about sort of Dr. Joshua White's and Dermatology Associates of Rochester. This is really, one of our earliest big wins. He's a dermatologist in Rochester, New York, I think, if in the case that wasn't clear. And he has like 4 or 5 offices, right, in Rochester, from like a med spa to Mohs Surgical Center to a standard dermatology practice, and maybe even like a clinical research lab. And it's 4 small locations, maybe 20 physicians, 60 employees, and they're doing great service in a community that needs it. They're one of the top providers in both bringing cutting edge tech and sort of solutions in the healthcare space to dermatology patients. And again, we met him early on in person. We were able to make the visit up to Rochester. We saw their spend, with a single supplier. We help them unlock 4 new suppliers. And it's a similar story, right? But the difference is like the impact, right? This is these smaller physician-owned medical practices are struggling to stay afloat as private equity has been gobbling up, all of these private practices. You see less private practices, probably wherever you are listening or tuning in from. There's less private practices, and the big hospital from the big city nearby probably bought the private practice that you used to go to. If it's not the big hospital, then it's private equity buying it out, and it's getting a new brand that's more familiar that you'll see all through the neighboring towns and neighboring cities, right? The little guys have been struggling to compete and stay afloat in a time where this conglomeration effect is sort of taking place. And we'll see how the conglomeration, or the consolidation plays out in the long term. And it's really not my place to say, if it's good or bad for society. I do know that generally costs go up for patients as these things get consolidated. Generally, the quality of care goes down. The owner who had a stake in performing for his patients, that fades away. He sells out, he starts going on vacation, and he loses touch. So like, these are anecdotes I hear from our doctors, but saving, and again, it's saving something like 40-50%, but saving 40-50% for Dr. Joshua White's and Durham Rochester is the difference between, right, like struggling to stay in business and having a killer year and being able to get an extra pair of hands, right, a medical assistant, or see more patients, or keep the office open on this day, right? Like the impact is something that we can see, we can feel, we both see it in the patients and how they appreciate it. The owner is the doctor who is the one that opens the supply cabinet and feels and sees the shortage and feels like screwed, right? Like, it's not corporate guys in ties saying like, wow, good job, we've saved a lot of money. It's real people, it's real patients, and the ones who feel what Grapevine's doing are the same people that remind me of my mom and dad, right? So those are the ones that move me and really keep me motivated and going.
Fantastic. Well, I think that brings us to the end of this episode. Thank you, Luka, so much for sharing about your company and your platform and the struggles that the healthcare industry is facing right now, trying to deal with their own supply chains. If any of our listeners out there have a topic or suggestion for what we could talk about next time on the show, we'd love to hear from you. If you'd like to be a guest on the show, like Luka, we'd love to hear from you as well. You can email me anytime at podcast@meebach.com. As always, thanks for listening to Speaking of Supply Chain. If you've enjoyed the show, please rate and review us on whatever podcast platform you prefer. We are on Apple, YouTube podcasts, and Spotify. And be sure to tune in next time.